This conference will now be recorded.
So welcome to the CPHQ training program, and just to talk about our organization, since 2006 we have been conducting a lot of training programs. Thanks for introducing yourselves, and let me introduce you to the very basics of CPHQ, what exactly certified professional in healthcare quality means. Towards the end of the program, we'll talk about more in detail, and I won't spend too much time here in this. One of the reasons is that you already have got a lot of information on NAHQ website related to this. So if you want, you can always go to the website and see the details, and these details are available on nahq.org website. Okay. So National Healthcare Association of Healthcare Quality is a membership and certification organization comprising of more than 14,000. So at times it is 16,000 because it keeps changing. The reason being some people choose to renew the certification and some people let it go. So you have to renew the certificate every 3 years. So around at any given point of time, 14,000 to 16,000 people are certified professional. Of course, I'm not aware of the real number as of now, but it is definitely close to that. It's a prestigious certification. It's valid worldwide. It is recognized worldwide. It incorporates the knowledge in the healthcare quality. It includes management and leadership. It includes the information management, data collection, data analytics in healthcare, performance and quality measurement and improvement in healthcare, and also topics related to patient safety. You will get a good recognition, and as the healthcare is continuing to evolve, more and more staff in healthcare organizations will be involved in quality. And how important is quality, all of us know, especially in healthcare. So the importance of learning the quality tools and techniques, which was earlier restricted to only the quality professionals or so-called statisticians who would improve the quality of the processes by just consulting the organizations and hospitals. Now quality has become everyone's responsibility, and if the awareness of the basics of quality is there within the whole hospital, everyone is aware of these data analytics tools and information management tools, and also aware of the importance of leadership. In that case, naturally, it is going to help the hospital achieve its strategic business objectives. More about the CPHQ exam I'll be talking about a little later, but very briefly, 140 questions. Out of these 140 questions, you have 125 questions to be definitely they will be scored, but you have to answer all the 140 questions. So you can't skip because you don't know which are scoring questions and which are pre-test questions. So in every test there are 15 pre-test questions. So it is very important for you to know that, because if you are not able to answer, like say suppose you are stuck on some question and it's taking more than 2 minutes to answer any question, then you need to just skip that question and move on to the next question. This is an important tip for appearing for the exam, because some people, if they spend more time on one particular question, you don't have time left for other questions, and maybe this particular question might be a pre-test question. So be aware of that fact. So types of questions we'll talk about later, and I will tell you about what is there in the syllabus of NAHQ. So as I told you already, there are 4 basic modules in NAHQ. The 4 basic modules in NAHQ are organizational leadership, which contains 35 questions. Then we have got the second module is health data analytics, which contains 30 questions. Then we have performance and process improvement, which has 40 questions. And then we have patient safety, which has 20 questions. Now, based on so much of data which we have collected in the past and looking at the types of questions, what we have observed that organizational leadership, this first module, and the last module, which is patient safety module, you will see that no one really fails in these modules. So you are successfully able to answer the questions in patient safety on organizational leadership if you have spent at least 2 years. So 2 years in the hospital. So minimum 2 years if you have stayed in any hospital, definitely you would be able to answer these questions. Of course, we'll be taking you through this model because you'd like to know what is contained in these modules. So we'll be talking about that, of course. But the most of the failures occur in CPHQ examination, and people find it very, very difficult in the health data analytics. That is 30 items, 30 questions, plus the performance and process improvement, which is 40 questions. So around 70 questions, they appear to be a little difficult. The reason is they are a little bit statistical in nature. So you have got, you can't make a guess there. Like in organizational leadership, you can make a guess. In safety, patient safety, more or less you are aware of the basic norms of safety, and you should be able to answer these questions, because if you worked in the hospital, definitely you have been trained for a good number of hours in patient safety. But the other techniques, mostly you are not exposed to unless you are a green belt or a black belt, or you have done some data analytics courses, which is highly unlikely in a healthcare industry. You may not be knowing about it. So we'll be emphasizing, and we'll be starting our module today with the health data analytics and performance and process improvement, these two modules. First, we will cover these modules. So first, we'll try to cover the health data analytics today as much as possible. We'll continue it if we are not able to finish it. We'll spend a lot of time on that. Then we'll go to the organizational leadership tomorrow, maybe in the afternoon session. And after that, I think if we have got time, I think better we'll spend third day on patient safety, and then we will revise everything on the third day. So we will be going as per the pace of the learners. So depending on how are you asking the questions, how much you're participating, so our pace might vary, but the sequence of covering the modules will be like this. So first we'll be covering the data analytics, then after that process improvement, and then after that organizational leadership, and then finally the safety. In fact, patient safety, you would be knowing much more than what I can tell you. Okay, so let me give a brief overview. What is there? What are the topics we will be covering in our organization leadership? Before I also talk about that, we have given you one book, which is again by NHQ. So if you read just this book, whatever I am going to cover in this training program, each and every word is coming from this book. Okay, so although there are so many books in the market, very famous books are there, you must have got nowadays, all the books can be easily downloaded from the website, or your friends will be able to give those books to you. So you will have lots of books with you. But what I sincerely request, because see, if you are studying on your own, then it's always good to read the Janet Brown book or some other books, whatever book you would like to read. But if you are attending this course, then you don't have to read any other book, although we'll be giving you all these books to you. But If you just read through this book, which is given by NAHQ, just read through this book, this is good enough. Just read through this book after attending our session. You will 93 to 95% with confidence, I can tell that you will pass the exam. Just reading. I'm not even telling you thoroughly memorizing anything or trying to remember anything. Don't try to remember anything. Please don't try to remember anything, because unless you want to become a trainer, of course. If you want to become a trainer, then of course you most welcome. You please remember all the topics and remember the examples, etc. But if you just want to appear for the exam, and please focus on passing the exam at the initial stages, just understand what is being said. Just understand what is being said, and that's good enough. So I repeat, just understand what is being said in the class. That is good enough. You'll be very well prepared. After that, of course, go through this book. The presentations which we have given to you have been made from the same book. So whatever is mentioned here, we have pulled out, we have applied Pareto analysis. Pareto means 80-20 rule. 80% of the marks you will get from 20% of the syllabus. If you remember your in school days and college days, although the book used to be so thick, but professor will tell you, or some of your colleagues will tell you that just study these pages. These are the important chapters. These are the important questions, and you will study these pages and you will pass the exam. So here, target is to pass the exam and not really master the subject. Of course, I'm not saying that you should not master the subject, but primary goal should be, while we are applying the Pareto analysis, primary goal should be passing the exam. So for that, I'm giving you a technique in the initial stages, and I'll keep reminding you in between. Having said that, no one is stopping you from mastering the topic. So the way we will be teaching you, we'll be going a little bit more in depth than what is expected from a CPHQ professional. So we'll be telling you a lot of things, like although as a CPHQ you are not expected to know central limit theorem, but we will tell you central limit theorem because you are expected to know about 95% confidence interval. Now you won't understand 95% confidence interval in depth if you don't know central limit theorem. So some of the things we'll be explaining to you while telling you that this is definitely not part of CPHQ syllabus. But this is being told you to build a strong foundation so that you can answer the questions and you'll understand the concepts. Okay, so this is one book which is already given to you, and you can read through that after you have completed the session, before you are appearing for the exam. So I'm just telling you right away, because later on also I'll repeat the whole thing, and I have made some videos also for 2 to 3 minutes where I explain exactly what you should be doing just before the exam. So that videos also will be forwarded to you. Okay. Now let us see the 4 modules. Let's look at the bigger picture of all the 4 modules. The first module is organizational leadership. Organizational leadership. So all the problems, all the errors in the hospital, poor quality in the hospital is the responsibility of the senior management. And I'm not saying that. Dr. Deming, one of the quality gurus, he said that all the problems, all the issues, any quality related issues is the responsibility of senior management and the leadership. So it is important to develop an excellent leadership devoted to quality. Now you would say, who is the leader? In fact, you are the leader. It's not that only the CEO is the leader, or the COO is the leader, or the governing board is the leader. You yourself are the leader, because you are also leading a team. So when we talk about organizational leadership, we are talking about ourselves. Having said that, of course, the main responsibility of the senior management is to create a vision which is linked to quality and patient safety. So it's very, very important for the leadership to show commitment towards quality by not only in words but in deeds as well. So for one of the first thing is creating an infrastructure so that it is able to support quality and quality initiatives and integrate the quality. That is why it is saying structure and integration. So organizational leadership is the responsibility of the leadership of the organization to create this structure and integration. So here, support organizational commitment to quality, participate in organization-wide strategic planning related to quality, align quality and safety activities with strategic goals. So for those who are new to this term called strategy, or strategy appears to be a jargon, then for them, let me tell you what is a strategy in short. Every hospital has got a vision. Every hospital wants to achieve something after a period of some time. So if you ask in hospital, you'll say, yeah, by 2025, I would like to be #1 hospital in cardiac surgery. Or by 2030, I would like to be #1 hospital in the whole country devoted to pediatrics. So this is the vision of a hospital. A vision of a hospital or any healthcare unit is coming from the mission. Mission is something which doesn't change. Mission stays same throughout the life of the organization. What is the mission? Mission is the purpose of existence of the hospital. So the people who established the hospital, they had a mission to accomplish. Mission, it won't be like something, a work. It is not something, a task, something like a task. It's a mission. Mission is like it is continuous. It won't end. It will be like something you will keep continuing to do. Just to give an example, Walt Disney, the mission statement is to make people happy. So for the last 100 years, their mission has remained the same. Their vision might have changed. So earlier stages, their vision might have been to become the #1 cartoon magazine in the world. Maybe there might be a vision by for 1940s or so. By 1960s, their vision might be that we would like to become the #1 theme park company in the world. By 1980s or so, I'm just making a guess, their vision might be to become the #1 cartoon film producing company in the world. Or now it might be, I'm really not sure about it, but if I just want to extend the example, it might be to become the #1 film producing company in the world or the entertainment industry. So mission remains the same, but vision keeps changing. So every hospital has got a vision. Now, to achieve the vision, hospital needs to do something. Now, there are 500 ways to achieve that goal. So if you want to become #1 hospital, there are 500 ways. Which way, which method, which route you will you choose. So the roadmap which you will be creating to reach your goal or the vision of becoming #1 hospital, that is known as strategy. Okay, so strategic planning. Strategic planning is something which is a plan created to achieve your goal, to realize your goal or realize your vision. So quality should be part of that strategy. So that should be integrated. And who will integrate? Of course, the organizational leadership will integrate. Align the quality and safety activities with the strategic goals. Engage the stakeholders to promote quality and safety. All these things we will be covering. Facilitating the development of the quality culture through councils and committees, encouraging the improvement projects within the organization, rewarding the employees who are doing PDCA projects or focus PDCA project or Lean Six Sigma project, then encouraging the best practices, participating in the activities to identify and evaluate innovative solutions, lead and facilitate the change, participating in population health promotion and continuum of healthcare activities, communicating resource needs to leadership to improve quality, and recognizing quality initiatives, impacting the reimbursement, etc. These are all part of the creating infrastructure and integration. Again, the responsibility of the leadership. Then comes the regulatory and accreditation, external recognition. So getting accreditations for the hospital, external accreditations like JCI. And then we'll see what is the process of doing that in short. Then we will also look at education and training and communication. The leadership is responsible for ensuring that there is adequate education and training for its staff, and the importance of quality is communicated throughout the organization. Lack of communication leads to a lot of errors, so this communication is established throughout the organization, and of course leadership has to ensure that. Then you come to healthcare data analytics, which we'll be covering anyway in great detail, so I'll not go into too much of detail right now. So today's agenda is this, so I'll not cover too much in the introduction part right now, but very briefly you'll be learning how to measure, what are the tools and techniques to collect the data, sampling methodologies, then how to measure anything, and you can't improve if you cannot measure. So how to analyze, you'll learn mean, standard deviation, correlation, different statistical tests, then how to interpret the data. There are different types of analysis, descriptive statistics and inferential statistics. So what is the difference between the two? And we'll talk about that. Then we will also learn about different techniques of improvement like PDCA, Lean, Six Sigma, etc. And then of course we will be seeing how to create an infrastructure for doing quality programs, then how to use different tools like FMEA, fishbone diagram, process mapping, and then finally, of course, patient safety, where we'll be talking about assessment and planning and implementation and evaluation. Here also tools like FMEA will be taught. So this is the overview of the 4 modules, and then we'll start with the first, as I said, healthcare data analytics.
This conference will now be recorded.
So let us talk about the most important topic in CPHQ, which is healthcare data analytics. So here we'll be learning about all these topics. One is introduction to quality. What is quality? What do you mean by healthcare quality? Then quality management philosophy, aspects and dimensions, some of the quality management pioneers, then introduction to statistics, descriptive statistics, inferential statistics, tools of displaying the data, tools for planning, tools for data collection, and tools for data display. And today you will find that unlike tomorrow and day after, on the third day, you'll find that we'll not refer to the slides more. We'll explain the things to you. The statistics needs to be explained to you. Once you have understood the statistics, then we'll be covering the slides, and you'll be able to understand all what is written in the slides very, very easily. So introduction to quality, let us talk about the quality management philosophies, quality, the aspects of the quality, the dimensions of quality, and some of the quality management pioneers. So healthcare quality has been defined as freedom from deficiency. So quality, it's very easy to define a quality by looking at the deficiency. If I ask someone to define quality, how good is some service or how good one product is, the person will find it very difficult to talk about it. But if I ask the same question, how many errors are there in a product or a service? How many defects are there in a product or a service? The person can easily say that there are 2 errors or there are 3 defects in your product or a service. So quality is always with respect to the product or the service. Quality is always, in our case, in healthcare, is about either product or the service. So if you are not providing what the customer wants, it is a defect for the customer. So what is 100% quality? 100% quality is freedom from deficiency. 100% quality means there is no deficiency, there is no defect, there is no error. Then there is one more thing which is included in quality, which reduces the quality. So even if you are providing everything to the customer, whatever the customer wants, but internally you did 3 reworks, means you did something wrong, then again you corrected it, then you did something wrong, then you corrected it, then you did something wrong, then you corrected it, and then finally you are giving that service to the customer. So although for the customer there is no defect, but from quality definitions perspective, still you are not at 100% quality. That means rework is considered as a defect. So you should do everything right the first time. Means if you are operating a surgery, so without committing a mistake, you should perform a surgery. And once you're performing a surgery, it should not happen that you committed a mistake and then after that you corrected it and final outcome was perfect, but that is definitely not 100% quality. So that is also included in that. Then having high degree of excellence. Having high degree of excellence means that whatever is the benchmark in the industry today, so you should try to maintain those benchmarks. So you should have a high degree of excellence, and of course safety is first. So if you are providing to the patient or any of your internal customer, because we are not always looking at the patient as the customer, even the internal department can be your customer. So when you are looking at your customer, so when we say customer can be patient or the relative of the patient, or customer can be a physician or a nurse or a lab or a pharmacy. So internal departments can also be customers of each other. So when we are looking at the customers, if they find a defect in our deliverable, whatever we are giving as an output of our process, if they find any defect, then in that case we say quality is affected. So quality is always measured in terms of number of errors or defects from customer's perspective. So in healthcare service, it is defined as the extent to which services provided to individuals and patient populations improve desired health outcomes. The care should be based on the strongest clinical evidence and provided in a technically and culturally competent manner with good communication and shared decision making. So if you are providing such a service, then you are at good quality. But if any of these things are violated, that means your quality is affected adversely. So that is what IOM's definition of healthcare quality is.
This conference will now be recorded.
So all the quality gurus, so there are 3 major quality gurus. One is Dr. Deming, one is Joseph Juran. In fact, there are 4 or 5 of them. So Joseph Juran, Shewart, then Ishikawa. Almost all of them said that leadership is responsible for all the problems in the organization. Okay, so here also it's true, and leadership is the driving force in creating. So on a positive note, if we put the same thing as on a positive, in a positive way, so we'll say that leadership is the driving force in creating and supporting the way people think about what they do. So it establishes the basis for procedures and focuses on the customer's need and satisfaction. The leadership role must be genuine and visible, with active participation in establishing, achieving, and rewarding the attainment of quality objectives. So you will see there's a quote by Dr. Edward Deming, which says 85% of the problems are due to the processes and only 15% is due to the people. So if you want to change The quality levels in organization, you should focus on processes. And obviously, who's responsible for establishing the processes? The leadership is responsible for that, not the employees, not the junior management, or not the executives. So focus on the processes, not on the people. And leadership should deliver or ensure the infrastructure, the resources, and adequate processes are in place so that organization or hospital is able to achieve its business objectives. So there are three aspects of quality whenever you are measuring. One more thing Dr. Edward Deming said, you can't improve if you cannot measure. You can't improve if you cannot measure. And the second rule is, now that I'm jokingly, I keep telling that, so you can measure everything. You can measure everything in the world. And this is also true for hospitals. So later on, we'll see how we can measure everything. But measures also can be from three perspectives. So one is provider's view, one is peer view, and one is recipient's view. So all three are important. Provider view means when I am providing a service, what is my view? As per me, how am I performing? If I'm performing really well, that is also a measure, because I know my process well, I know my internal settings well, I know whether my people are following the SOPs really as per the norms or not. So that is how I'm measuring my own processes, my own performance. That is provider's view, measurable quality. Then another is appreciative quality, which is like, how does my peer or an expert view my performance, my processes, my output? The perceptive quality is recipient's view, which talks about how does my patient or the person who's receiving my service view my quality. So MAP, measurable quality, appreciative quality, and perceptive quality. So these are the three aspects of quality. So to keep that in mind, so not only your view, but also the recipient's view matters. These are the different quality dimensions which you should keep in mind. STEEP, STEEP, safety, timeliness, effectiveness, efficiency, equitable, and patient-centered. So while you are measuring quality and while you are rolling out your quality initiatives, these dimensions of quality should be always kept in mind. So safety should be always of prime importance. Timeliness, reducing the waiting times, and also timeliness of delivery of the service of the whatever service you're providing. It should be timely, it should not be delayed. Effectiveness, how much you are able to achieve the desired outcome. Efficiency, effectiveness and efficiency, the difference between the two is, effectiveness means if you are delivering what you promised to the customer, that means you are effective. Efficiency means if you are delivering to the customer what you promised, but at a lesser cost, that is efficiency. So effectiveness is more from perspective of the external customer or your customer. It can be internal customer as well. Efficiency is more from the perspective of the stakeholders or the shareholders of the hospital. Just to give an example, effectiveness means like if I tell you to go to from point A to point B, and if you reach point B, then you are effective. But instead of point B, you reach point C, then you are not effective. So if you are achieving what you are supposed to achieve, you are effective. But what is efficiency? I told you to go to from point A to point B, and while you reached point B, you took 30 minutes, and someone else who also started from point A and tried to reach point B took 20 minutes. So in this case, the other person is more efficient. So efficiency is about doing the things in a better way. First, of course, you should be effective, and then you should think about the efficiency. So this is very important to know that sometimes in order to be efficient, in order to reduce costs, we start committing more mistakes. So it should not be like that. Effectiveness is more important than efficiency. Then equitable without any discrimination, and also it should be patient-centered. Other quality dimensions are appropriateness. So it should be relevant to the patient's needs. Efficacy, the potential capacity to achieve a desired outcome. Nowadays, we are talking too much about efficacy of all vaccines. So what is the potential capacity to achieve a desired outcome? What can happen? That is the efficacy. Continuity, are you able to continue the health service from one hospital to another hospital? So are your systems such that you are able to continue the like treating the patient if the patient needs to move from one place to another place? So if that is the case, then continuity is established. Availability, is the service available? Is the treatment available at the right time? Respect and caring, being sensitive to the individual needs. And competency, the practitioner adheres to the standards, and the practitioner is competent enough, got all the accreditations and certifications, and also preventing or early detection. So rather than just correction, how much you are emphasizing on prevention and early detection. So these are other quality dimensions which you should take care of. So effectiveness means the degree to which care is provided in the correct manner with the correct state of knowledge to achieve the desired outcome for the individual. So you are being effective if you are providing the care based on the current knowledge, whatever is currently available. If you're following those norms, you're following the standard operating procedure, that means you are being effective. And efficacy means the potential capacity or capability to produce the desired effects or outcome as shown in the scientific research. Yeah. So like evaluation of number of patients who have polio vaccine after receiving polio, who have polio after receiving the polio vaccine, that will be the efficacy. Or another example, nowadays we can say what proportion of the people are developing the antibodies once they get vaccinated. Then I think we will continue after the break. So this is the break time right now. So we'll take a 15-minute break, and after 15 minutes,
This conference will now be recorded.
So whenever you're talking about quality, we have to collect the data. So we have to make a judgment about any process or any product or any service based on the samples. And when we collect the samples, based on that, those samples, we need to draw a conclusion about the population. So whenever we are drawing a conclusion about our population, we are creating a hypothesis. So suppose I collect the data of 20 people from a population, and I want to know their heights. So in this case, collecting the heights of or trying to gauge an information about the heights of the whole population, or what is the average height of the whole population, by collecting just 20 samples is known as sampling procedure. So when we are collecting the samples, the primary reason for collecting a sample is to first describe the population. That is one thing. And the second one is to draw an inference. Because most of the time, quality is not only telling that you are really not performing well or you are performing well. It's not about that. It is about improvement too. Quality has got three areas. So let's look at what are the three areas of quality. So quality can be divided into three main branches. The three branches are the design, quality design, then management and improvement. So we have design, management, and improvement. So all of them are important. So designing generally, because we are into operations, most of us are working in hospital in operations, and some of you are working in quality as well. So definitely this part is very, very important. You can say, you can call it as process management. You can call it as creating an SOP. So someone will be designing standard operating procedures for you, and they will be making process maps for you. They will tell you how to perform a particular work, and they will also give you some KPIs, key performance indicators, that you need to maintain your performance within these parameters. So when you are doing this, we say that we are managing the processes. We are managing the quality. So if I want to pictorially represent this, so these are the KPIs, and you need to manage your process within those set parameters. And if you are doing that, we say that you are managing the process.
This conference will now be recorded.
So in an organization, most of the time in operations, someone has designed a process for you. They have created standard operating procedures. They have created process maps. They've also given you the KPIs. And you need to maintain, you need to operate the process within those parameters. We call it as quality management system. Then, of course, because of the environment, because of the competitors, because of the change in technology and the progress, which naturally is part of any endeavor of mankind, just maintaining your processes at the same level is definitely not the intention of any organization. It would like to improve. So maybe if I talk about waiting time of patients in the hospital, if you are right now maintaining it within, let's say, 15 minutes to 30 minutes, you would like to reduce it further to, let's say, 0 minute to 5 minutes. So this shifting of the process, operating at new levels, is known as process improvement. Process improvement. This is known as process improvement. So moving from stage 1 to stage 2 is known as process improvement. So here you will be using PDCA, Lean,
and Kaizen and Six Sigma. So these are the areas which belong to this category of quality. So quality improvement. So quality, if I just write quality here, you have quality here. Quality management system, QMS, sometimes we call it as quality management system. So suppose we are implementing ISO 9000. Some of the examples are ISO 9001. If you are implementing, you will say you are implementing quality management system. If you are getting accredited yourself with JCI or Sabahi or NABH, depending on which country you are in. So then in that case, you are establishing a quality management system. Quality management system. And then you are continuously striving to perform better, continuously improve the way you work. Then in that case, we say that you are striving towards improvement. In both the cases, both are important. Descriptive statistics is important and inferential statistics is important. What is descriptive statistics? Descriptive statistics just describes how are you performing. It just tells you that waiting time of the patients today is 30 minutes. It just tells you that infection rate in the hospital is 1%. It just tells you that medicine dispensing time in the pharmacy today is 20 minutes. Describing just tells how are you performing. Obviously, if you want to maintain your process, establish a process management system, you really need to measure, and descriptive statistics is important. But when you are drawing a sample and making a conclusion about the population, you just collected 30-40 samples, whatever you are predicting about the population may not be accurate. It will have a confidence band. Some inaccuracy, some error, bias might be there. So every sampling comes with a bias, comes with some confidence interval. We'll talk about that later. This is about descriptive. Descriptive means describing how I'm performing. Then comes the improvement. In the improvement, you would like to improve. So you would like to know first why I am not performing to the desired level. So there are two scenarios. Either you are not performing as per the desired levels, as per the designed levels, or you would like to improve further. You are already performing. Patients really like you. Your stakeholders, shareholders, your senior management, everyone is telling that you're really doing pretty well. But still, your you can say the environment, the competition, the market is like that you really need to improve. And of course, your vision is to become number one. Then of course you can't rest on the past laurels. You really need to work hard. So in that case, you need to continuously improve your process. Now you would like to improve the process. Then first thing you would like to know is why I am not able to achieve this. What are the factors preventing me from reducing my waiting time? And then associating these factors with your output, with your measures, which you are interested in, is known as inferential statistics. Like, for example, telling that waiting time is 30 minutes is descriptive statistics. Now, drawing an inference that my waiting time is high because it is taking too much time in the registration process. So this is drawing an inference. We call it inferential statistics. So in the improvement part, we'll be discussing about the inferential statistics. Both are important. But of course, there is something which is design as well, which is of course not in our scope. So some experts will design those processes. For experienced people, they will design like what levels you should be operating, what should be the right procedure for treating patient, etc. So all these things will be designed by the experts. So quality professional is for a quality professional, you can say that it's important for us to understand The quality management system and quality improvement, they are two different things. Both are important. If you are managing your quality well, you can think of improvement. So first is, of course, you have to establish the process management system, then you can think of improvement. So the descriptive statistics deals with the enumeration, organization, and graphical representation of data. We'll see how to do that. And then later on, we'll see inferential statistics concerned with reaching conclusions from incomplete information, that is generalizing from a specific sample. Now, I told you that there are two types of data, and also I told you that you cannot improve, you cannot measure. And the second rule is everything can be measured. So let's talk a little bit about that. So we need to understand that there are two types of data. Okay. The two types of data are continuous data and attribute data. Continuous data and attribute data. Continuous data, you have like waiting time, patient waiting time, 30.5 minutes. Patient discharge time, 4.2 hours. Height of a patient, it is centimeters, and so on and so forth. So you'll always see that a continuous data is a data which can be represented on a number line. It always has a unit, minutes, hours, centimeters, kgs, and if there is a possibility of a decimal place, means continuous data is known as continuous data because it can be represented on a number line, number scaling. This is number scale. This goes from minus infinity to plus infinity, means goes on and on. Any number is possible. So any point on this number line, like 24.3, is possible. So because it's a continuous scale, we call it as continuous data. So much of the data which you deal with can be represented as a continuous data. Also, other name of this data is variable data. Other name of this data is variable data. Another type of data is attribute data. Attribute data is data which we feel is difficult to measure, and it's not so easy to measure, obviously, like continuous data. So it takes a little, you have to really do something special about attribute data. What is that something special you need to do? First, you have to understand which attribute you want to measure. And then, of course, you create category of that attribute. And then, of course, you have to create the count. And then, of course, you have to have a proportion. So when you're talking about the attribute can be like pain, very difficult to measure. But here, easier way of measuring anything. Let's say if I say pain, it can be pain, no pain, or it can be a range of 10, extreme pain, See, very severe pain and no pain at all, 1 to 10 scale. So whenever we are talking about attribute data, the easiest way of putting a category is presence or absence of that particular attribute. Sometimes people say it's very difficult to measure satisfaction. So you can say satisfied, dissatisfied. Sometimes people say it is very difficult to measure the say happiness. So you can say happy, unhappy. So the basic two categories definitely can be easily created. And then you have to always look at the counts. So in a patient, like I'm checking the patient, let's say in a day 10 times, and out of 10 times, 6 times he had pain and 4 times no pain. The proportion was 0.6 and 0.4. So it depends on the purpose of using the data, what exactly the data is being used for. And based on that, you will be creating your attribute and the categories. In both the cases, let's say I can use another example, patient satisfaction. Patient satisfaction. Patient satisfaction can be on a 5 scale. So very, very happy patients, and happy, and then neutral, and unhappy, and extremely dissatisfied. And in my hospital, I checked with 100 patients. And then we see that 40 of them are very happy, 30 of them are happy, 10 of them are neutral, and 5 of them are unhappy, and 15 of them are extremely unhappy. And then I can get my relevant proportions. So if I just look at the descriptive statistics, anything, either I take height or discharge time or patient waiting time. So if I take a discharge time, let us say, if I am talking about descriptive statistics, how to describe? Describing the statistics. When I am dealing with continuous data, I can make a histogram. Okay, I can make a histogram. But this is something which I had already covered in the introduction part of CPHQ, but I'm just repeating it because some of you have not attended that. When I'm dealing with attribute data, I will not be able to make a histogram. Then I'll make a pie chart. I can make a pie chart. I can divide the observation into different categories depending on the proportion. Or I can make a bar chart. I can make a bar chart. Or I can also make a Pareto chart. So all these tools are part of your toolkit in CPHQ. Sometimes they will show you the chart, and then they'll ask you a question. Based on this chart, answer these 2 questions. So you have to answer these questions, and they are, as long as you understand those charts, you should be able to interpret them very, very easily. So this is about descriptive. So descriptive statistics just describes. Now let me talk about a little bit of more, going into the details of descriptive statistics. Now let us understand, if I'm describing a process, so what are the various ways of describing the process? So one way, of course, is the histogram. Another way is if I keep on collecting the samples, more and more samples. Suppose I keep on increasing the samples more and more. So what will happen? This curve will become smoother and smoother. But it won't give me much information, any if I expect that collecting more samples will give me more information, it is not going to give me that. It will just smoothen the curve like a bell-shaped curve. So let us talk about the bell-shaped curve a little bit in detail. This curve was given by Gauss, and he found that all the processes, all the repetitive processes, they follow this bell-shaped curve, which has an average. And then he said that if I collect around 30-40 samples from any population, I can fairly accurately estimate the shape of the curve. And he said that if I collect 30 samples, you will get an average and you will get a standard deviation. So let us talk about what is average and what is standard deviation. And he also said that these both are important. Mean, like the central tendency in your data, that is also important. And the variation in the data, that is also important. So sometimes we are just focused on central tendency and we ignore the variation. Both are important, and how important they are, let us take an example. Before that, let us talk about how will I measure the central tendency. So if I take any data, let us say the patient discharge time, and if I measure in, let's say, minutes, say 300 minutes, 330 minutes, 340 minutes, 280 minutes, 270 minutes, and so on and so forth, I keep collecting the data, I will get an average, let's say 300 minutes. And I will also get a standard deviation, which I can very easily calculate using an Excel sheet. I will tell you the formula also. They will not ask you the formula in the examination, but I'll just very briefly touch upon that because some of you might be interested in that. So standard deviation can be easily calculated, and let us say standard deviation in this case is 30. So based on this, I can predict about the population. So what am I doing here? I am taking a sample, 30 to 40 samples I am taking. But based on the 30 to 40 samples, I am trying to predict about 3,000 patients being discharged by my hospital in the whole month. How am I able to do that? By following Gaussian theorem. This is a Gaussian curve. Yeah, Gaussian curve, right? So let's say average is, this is average 300 minutes. So this will be 300 plus 1 times standard deviation. 1 times standard deviation. This becomes 330 minutes. Then 2 times standard deviation. 2 times standard deviation becomes 360. And 3 times standard deviation becomes 390. Similarly here, it is 270, 240, and 210. Okay. This will be the behavior of the population. So by just collecting 30 samples of patients, I can predict about all the 3,000 patients being discharged from the hospital, saying that 99% of my patients, 99% or 99.73% of the patients in my hospitals are being discharged within 210 to 390 minutes. It is again describing, it is not telling why, it's just describing. So another way of describing your state of the process is based on the average and standard deviation, you create a control chart. So let me talk about that as well. So minus 3 times standard deviation is known as lower control limit, and plus 3 times standard deviation is known as upper control limit. So if I want to describe my process, I can also make a control chart. I can make a control chart. How I can make a control chart? By putting a lower control limit here, which is I would say 210 and 390. So 210 LCL and UCL 390. So if I want to describe the present performance of the process, I will say that process is moving, and if you track the patients being discharged in the hospital, they will be around 300 minutes on an average, and they will be taking plus minus 3 times standard deviation, but like it will go up from 210 to 390. Never it will go above 390, and never it will go below 210 minutes. This is how I will describe it. And this is also known as voice of process. Means process, if it had a voice, it is trying to tell you that yes, if a patient is being discharged, I will take 210 to 390. Why? Right now we don't know. But if a generic statement needs to be made, so process will tell you, if I ask the process why you are taking 210 to 390 minutes. So process would say that, well, the way your SOPs are, the standard operating procedures are, the way you have trained your people, the way you maintain your equipment, the kind of facilities you have, the way you interact with the different departments within the different departments. All these things are going to give you 210 to 390 minutes day by day, week on week, month on month. And I won't change unless you really do something about it. Okay. So this, right now we are restricting ourselves to the descriptive. So descriptive statistics means 210 to 390 minutes. This is I'm describing. How I'm describing? Just collecting small samples, a little bit of samples. 30 to 40 is a thumb rule, but there is a sample size formula also, a 95% band as well, which we'll describe in a short while. So this lower control limit and upper control limit, these are known as the control limits. And if your patients are being discharged within 210 to 390 minutes, then we say that your process is under control. We say that your process is under control. Process of discharging the patient is under control. It doesn't mean whether the patient is happy or not, or whether your senior management is happy or not. Process being under control just means it is under statistical control. Then there is not, it is a predictable process. I can predict that it is between 210 to 390 minutes. But it doesn't mean that it is performing really well. How will I know whether it is performing really well? By seeing, are the control limits within the specification limits? So I've got another limit which is given by the customer. Here the customer can be the management, customer can be the patient, you conducted a survey, or it can be a competition. In a competing hospital, you are able to discharge the patient in, let us say, 100 minutes. Or your senior management says that you should discharge the patient within 100 minutes. Or the patient tells you that I need discharge within 100 minutes. So this is known as specification limit, which is 100 minutes. So ideally, your process should move from here to here. And once it moves from here to here, this is known as improvement. Here you'll use PDCA, Lean, Six Sigma, etc. These are the techniques which we'll be learning very briefly. So you don't have to master those techniques in CPHQ. You should be aware of these techniques. You should be having a basic understanding of those techniques. So this is about the descriptive statistics. But suppose I'll talk about the control charts a little later, but giving you a brief introduction to the control chart. If I look at this data, if the patients are being discharged within 210 to 390 minutes, I will say the process is under control. But suppose a patient got discharged in, say, 480 minutes. So then I would say that something special has happened. This is not the way we operate. Something special has happened. So what is the something special happened? The operations person will know, the nurse will know, the physician who's involved in the process might know, or the pharmacist might know that there will be one special cause. Everyone can say, well, this happened because of this. But it happens just sometimes. It just happened once. It's not going to happen tomorrow or day after tomorrow. It's just one off. It's like an outlier, one of incident. It's an outlier. So in this case, operations persons need to take an immediate action, but the quality professional doesn't have to worry too much about it because it's an outlier. Quality person is more worried about the control limits, 210 to 390 minutes. This I need to bring it to below 100 minutes. This 480, well, I can get some hints about how to improve the process or what can be wrong with the process, but this is not my primary area of concern. That's what a CPHQ would say. But operations person, the nurse on duty, definitely should take care of that. It's not that we are ignoring that point, ignoring that patient. There must be some special thing. We need to adhere to the norms. We need to look at that particular case, and we have to take an action. But a quality professional, I'm talking, we are talking from the perspective of the quality professional. Quality professional will ignore the outliers. We will ignore the points which are out of control. So we will say this point is out of control. So in short, we will say this variation within the control limits. Variation within the control limit is due to common causes. Why we are saying common causes? Because if I ask you why this is varying, let's say discharge time is varying in our hospital, you can draw a cause and effect diagram saying that my discharge time is varying in my hospital. Discharge time is varying in the hospital because of so many factors, like time taken to write the discharge summary, or some errors in the report, or relative of the patient not available, and so on and so forth. Of course, I can fill this cause and effect diagram. If you give me half an hour, the whole team can fill this cause and effect diagram. And we call this as X factors. This we call it as Y, the outputs and the inputs. So process and input parameters. Now, if I ask again, if I go back to this question, why this some patients are taking say 240 minutes, some patients are taking 300 minutes. Why? Because of all the causes collectively, all the causes, there's so many causes acting on my system. I can't pinpoint to which cause is acting on my system, but all the causes are acting on the system and producing this variation. This is known as common cause. So commonly these causes are acting on my system and producing this common cause variation. So this usually you will see these questions, whether this control chart exhibits common cause variation or special cause variation. So we will learn about how to identify this common cause and special cause. So common cause means it's at random. All the causes acting on my system and producing this variation is common cause variation. But this particular instance is a special cause, and here I would say that, well, one cause I can attribute, I will say discharge summary took long time because the physician got busy with some surgery or something. or it can be a special cause. It doesn't happen often. It's a special cause. So we say it's a special cause. So there are two types of causes when you are looking at the control charts: common cause and special cause. Please remember that, common cause and special cause. So right now we are talking about again this descriptive statistic. Descriptive statistic, you can make a histogram, you can make a control chart, you can make a run chart. So we'll come to the run chart a little later, but run chart is just like simple without any standard deviation. I'm just putting one patient took 300 minutes, another patient took 310 minutes, another patient took 290 minutes. Just putting the points without any control limits. And then whatever I observed, a line which divides all the observed points into two equal parts. Like for example, 50% of the data would be above that and 50% will be below that. We call it as a median. So if I'm drawing a median and plotting the chart on it, I will call it as a run chart. Run chart. So in order to understand what is mean, what is median, and what are the central tendency, measures of central tendency, let us learn about that. Let us learn about the measures of central tendency. As I told you earlier, both are important. Central tendency of the data is important, means if we are talking about the heights of people, age of people, blood pressure, glucose levels, whatever. Central tendency is also important, and the variation is also important. Central tendency is measured by mean, median, and mode, and the standard variation is measured by range, interquartile range, and standard deviation. Okay, so we have got various measures. Central tendency you can measure by mean, median, mode. Mean means, average. I think everyone knows what is mean. You have the data, add the data together, divided by number of samples. Just to take an example, if I want to calculate the central tendency, of this data, which is 7, 11, 13, 14, 6, 5, 7, 9, 4, and 7. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And let us make one more, which is, let's say, 3. So to make to calculate the average, what I will do, I'll add all the numbers together and divide it by number of samples. So how many are there? 3, 4, 5, 6, 7, 8, 9, 10, 11. There are 11 samples. So what I'll do, add the numbers and divide it by 11. I'll get my mean. That is my mean, average. What is the median? I'll put this in descending order. I'll put it in descending order, and of course, I'll put it 14, 13, say 11, 9. Just put here, so 14, 13, 11, 9, and then I'll have 7, 7, 7. Okay, 777. And yes, you can help me. You can keep writing your answers as well. So 14, 13, 11, 9, 7, 7, 7, and 6, 5, 4, I think. 6, 5, 4, and 3. So what is the median here? You can write in the chat. What is the median here? So what I will do, first I will divide the data into two equal parts. I'm putting in descending order, highest to lowest or lowest to highest, anything. And 1, 2, 3, 4, 5 here. 1, 2, 3, 4, 5. So 7 is the median. Yeah, 7 is the median. Okay. Then comes, this is the minimum. This is the maximum. I can even divide the upper half and lower half also in two equal parts. So I can make, we will call it as quartiles, because now I'm dividing into quarters. So quartiles. This we call it Q1, this becomes Q2, and this becomes Q3. So I've divided the data into 4 equal parts, quartiles. If I divide the data into 10 equal parts, then it will become decile. If I divide the data into 100 equal parts, then it will become percentile. So the 100th percentile will be not actually 100%. 100 percentile means the highest number in a given data. And 0th percentile will be the lowest number in the given data. 50th percentile will be that number below which 50% of the data is there, and above which we have 50% of the data. And if it is quartile, then in that case, quartile will be 25%, 25%, 25%. So here, if I just say 50, 50 above this, and 50 below this, median. If it is 25%, 25%, 25% of the data, not the values. Please remember, it is nothing related to the values. Number of data points. But in mean, values are important. In median, values are not considered. So that gives a little advantage of median over mean when you have outlier. So when you have an outlier, let's say you have an outlier, suppose this data was not 14, but 140. So if this were 140, mean would have really become higher, but median won't change. Even if it is 140, the median still remains 7. So when you have got too many outliers in the data, then you can use median. But when you have got no outliers, the process is under control, it's normally distributed, then you will be using mean. So mean, median. Mode is most frequently occurring data. So here what is mode? 7. 7 is 3 times it is occurring. That is why it is 7. In the normally distributed data, you will find that mean, median, mode all will be same. The normally distributed data, the mean and median and mode all will be same. Mode, because this is the most frequently occurring value. Maximum times it is occurring, it's mode. But in non-normal distribution, it will be different. Mean will be different, median will be different, mode might be different. This might be the mode, mean might be somewhere here, and median might be somewhere here. Actually, you need to calculate. So the normally distributed data, it looks like a bell-shaped curve. And if it is not bell-shaped, we call it as non-normal data. Again, we are talking about descriptive. We are still in the descriptive stages. We are describing our process. We are doing a histogram. We are doing a control chart. We are doing a run chart. We are learning those techniques of how to describe our process. Once so I collect the data. After collecting the data, I would like to know how my process is performing by looking at two important characteristics, which is central tendency and variation. So we have seen central tendency, mean, median, mode. Now let us look at the variation. Variation is very easy. Variation, if I want to calculate using range, it's very obvious and very easy. If I want to calculate using interquartile range, you have to do a little bit of calculation, but it's still easy. But standard deviation, you have to apply a formula. Let us look at the first range. Range is the maximum minus minimum. It's very easy. Range is maximum minus minimum. You can always calculate the range for any given data. Maximum minus minimum. Interquartile range means Q3 minus Q1. So advantage of interquartile range would be over the ranges. Range is again affected by the outlier. So suppose this is 140. What will happen? Range will become too large. But interquartile range will not get impacted. So that is why we are looking at IQR when we have outliers in the data. How will I detect outliers? Very easily, if I plot on a graph, you will be able to detect. Now, they don't expect you in the examination to plot a chart or do some hypothesis tests or perform in-depth analysis. So all the analysis will be given to you. It will be presented to you in the form of a chart or an information. You have to interpret correctly. So in order to make you or learn you to interpret correctly, we are teaching you some of the theories as well. So I'll keep telling you that some of the things which we are training you a little bit more in depth so that you are able to understand the bigger picture. So range, okay, so this part, sometimes they ask like mean, median, mode, what exactly it is. And range and IQR, percentile. Percentile means dividing the data into 100 parts. So every group contains like 100 data. So 100 means 100 percentile will be the highest number and 0th percentile will be the lowest number. Mean, median, mode, range, interquartile range. Now comes the final thing, that is standard deviation. So how do I calculate standard deviation? So I see that now I think we are about to come to the second break. So what I'll do, I'll take a break, and after that, after the break, we'll talk about the.
This conference will now be recorded.
So when we look at this data, we have divided the data into 4 equal parts. At times, we even combine the Q3 and Q1 together, and the maximum to Q3 and this to Q1 to be minimum. And we call this graph as a box plot. We call it as box plot. What we have created is a box plot. Box plot, what it does, it divides the data into 25% of the data lies within Q3 to maximum, minimum to Q1 lies 25, and Q1 to median lies 25 and 25. And interquartile ranges Q3 minus Q1.
This conference will now be recorded.
Let us look at the other part of the standard deviation, the variation, range, IQR. Now standard deviation, we saw range and IQR. Now let us look at the standard deviation. Standard deviation can be understood in 2-3 different ways, but the simplest expression of standard deviation would be it is the average deviation of each of the reading away from the mean. But how is it expressed? So in order to understand the formula, but as I told you that you don't really have to remember the formula, although long time ago, 2-3 years ago, we used to see that some questions had been asked where you use the formula, but no longer we don't observe such a thing happening now. But because it's part of the syllabus, so we'll just cover that. But I'm trying to derive the formula. This part is definitely not to be really, this is not required to go into so much of detail, but I'm 5 minutes, I'm going to talk about standard deviation in a little bit detail so that some of you will understand what is the essence of standard deviation. So let us say that I have, say, 2 vendors, vendor A and vendor B, and I want to have any item, let's say a marker or a pen, something with the specific length. So it can be a syringe, it can be a pen, it can be any item. Let us say I ask for 7 inches length of any item, and I have got 2 vendors, and I collect a sample of these 2 vendors. The first vendor is giving me, say, 5, 6, 7, 7, 8, and 9. Another vendor is giving me 5, 5, 7, 7, 9, and 9. And if I look at the average is same in both the cases. And standard deviation is, range is also same in both the cases. Range is maximum minus minimum, it is 4. This is also 4. In this case, I'm not able to differentiate between the 2 set of readings. But if I carefully look at the samples of A and B, and if I had specified the item to be 7 inches, as the specification is 7 inches, if I look carefully or observe carefully, which vendor you think is deviating less? Means which vendor is closer to what you want? You want 7, so which vendor is closer to what you want? So here you've got 2 vendors, A and B, 5, 6, 7, 7, 7, 8, 9, 5, 5, 7, 7, 9, 9. Now these are the samples drawn from, say, if I'm taking marker, let's say this marker, the length should be 7 inches. I ask for 7 inches. The vendors are supplying with some variation. So which vendor is closer to what I want? A or B? So A is closer to what you want, means here the deviation of A, like I wanted 7, so the A is deviating a little bit lesser as compared to B because B is deviating too much, the 2 extreme values. Now if I want to measure the spread or variation in a process, there are 2-3 ways of doing it. So let us take some example. Let's say these are 2 large halls in a hotel, 5-star hotel, a banquet hall, let us say, and some people are having some conference there. And if people are sitting like this in X hall, and in the Y hall, people are sitting like this, in which hall you have bigger spread? spread is bigger in Y or X? Yeah, so the spread is in Y. Y is having more spread. So one of the ways to measure the spread or the variation present in the data is, what I will do, I'll first calculate the center, the average, and I will measure the distances of all the readings from the center, individual readings from the center, and I'll divide the distances by the number of samples. Here, obviously, the sum of all these distances in case of Y will be more than X. So mathematically, I can express this as X minus X bar. Mathematically, I can express this as X minus X bar. X minus X bar means 5 minus 7. 7 is X bar. X bar is the mean of the sample. So this will be minus 2. This will be minus 1. This will be 0. This will be 0. This is 1. And this is 2. And here, if I do the same thing, 5 minus 7 is minus 2, 0, 0, 2, and 2. So mathematically, I'm just putting that the distance is like X minus the mean. And if I take the sum total of that and divide it by number of samples, so if I take the sum total, I will get only 0. So still I'm not able to differentiate between A and B, that variation in A is higher than B. So what I'll do, I'll sort of play a trick here. I will square these distances, and then later on I'll take a square root. Like in school, if you remember, if I square something and take a square root, I will get the number. But in the whole process, I'll remove the minus sign, which will be of use to me. So what I'm doing, minus 2 into minus 2, I'm multiplying minus 2 into minus 2, is 4. And here it is 1, here it is 0, again 0, 1, and 4. And here again it is 4, and 4, and 0, and 0, and 4, and 4. So if I take the sum total of X minus X bar square, it comes to 10 here, it comes to 16 here. So this is a better picture of the variation. Means I can say that now B, the sum of squares is very high. Sum of square is higher. This we call it as sum of squares. Now if I take the average, so 10 divided by the average and 16 divided by average. So divided with the number of samples. So how many samples are there? 1, 2, 3, 4, 5, 6. If they are samples, I will divide by n minus 1. Means if I have 6 samples, I will divide it by 6 minus 1. So here I'll divide it by 5. If it is sample, here also this is a sample, it is not the whole population. So if it is sample, I will divide it by, again, 6 minus 1, that is 5. I'll tell you a little later why n minus 1. A brief explanation I'll give because it's beyond the scope of our CPHQ discussion, but brief explanation, layman's explanation I'll provide you a little later. So now I have got a value and I can easily say yes, B is having more spread. We call this as variance. We call this as variance. And if I take the square root of variance, means because I had taken a square, so I'll take a square root. This is known as standard deviation. Sample standard deviation is represented as small s, sample standard deviation. And when it is population standard deviation, so if this was a population, like all the markers produced by the vendor were available, So in that case, I will not divide it by n minus 1, then I will divide by n, the number of samples. And I will call this as population standard deviation. I'll call this as population standard deviation. So this becomes population standard deviation. So the formula for population standard deviation is sum of x minus x bar square divided by n, and formula for sample standard deviation is divided by n minus 1. Now, although I explained to you, you don't have to really calculate. There might be a very rare case that some data will be given to you and you'll be asked to calculate the standard deviation, although it is in the syllabus. But the application of standard deviation is more important for you to understand. So how to calculate standard deviation, nowadays softwares are there, and it's nowadays acknowledged that quality professionals really don't have to do any calculations manually. You have Excel sheet, you have got a lot of other softwares like Minitab. We will provide you with a Minitab software. If you are interested, you can learn that. A brief session of 15 minutes we will hold sometime towards the maybe end of the day or maybe tomorrow to get you conversant with Minitab. We'll be providing Minitab as well. But having given you Minitab, we'll also tell you that CPHQ is not going to test you in Minitab. But Minitab, we are giving you a little bit of half an hour session we'll be giving you so that you understand the usage of the tools, usage of those graphs, usage of the charts, the both descriptive and inferential statistics a little bit in a better way. So that is the reason we'll be giving you the Minitab. But you don't have to really be master in Minitab. Even if you see and understand what we are doing, that's good enough. So this is about standard deviation. And so for sample, it is this formula, and standard for population, it is this formula. Now, let us look at in the descriptive statistics, both standard deviation and mean, they will describe the whole process. Just to tell you just to give an example, suppose I take an example here. There are two hospitals, and I'll represent them with two different colors. So let us say one, I will say blue hospital, and one I will say red hospital. And let us take an example of, say if I take the example of discharge time of patients, so we'll take that. Average time taken to discharge a patient in a blue hospital is say 200, let's say 200 minutes, and the standard deviation is, let us say, 30 minutes. So this hospital will look something like this: 200 minutes, 1 standard deviation, 2 standard deviation, 3 standard deviation. And please ask me question if you are unable to understand why I am writing 230, 260, and 290. This is 1 standard deviation, right? So this is X bar, 1 standard deviation, 2 standard deviation, 3 standard deviation. Here it will be 170, 160, and 140 and 110. So the process will look something like this. In this blue hospital, patients are being discharged Or let's say your hospital has got two locations, blue location and say green location. I'm just taking an example, representing the locations as color. Now, if as per the KPI set by the government or your senior management, you should not discharge patients beyond, let's say 260 minutes, or let's say 230 minutes. So this is the specification limit, SL, specification limit set by the customer. And these are the control limits, LCL, UCL of Blue Hospital. So obviously I can see that some of the patients are being discharged beyond 230 minutes, and there are defects and dissatisfied customers in this, and there are quality issues in this Blue Hospital or Blue location. Now there is another hospital, which is Green Hospital, which is average is 260 minutes, or let's say 290 minutes. Let's move 260 minutes. Okay. And standard deviation is 10 minutes. Now Green Hospital, how it will look like: 260, 270, 280, 290, 250, 240, and 230. So the Green Hospital performance looks like this: 10, 10, 10, and 10, 10, 10. Are you with me? Have you understood what I did? If you are not understood, please let me know. I'll explain one more time. So the Blue Hospital average is 200 minutes, standard deviation is 30 minutes. Green Hospital average is 260 minutes and standard deviation is 10 minutes. Almost all the patients are being discharged. Almost all the patients are being discharged in the Green Hospital more than the specified limits. So I'll repeat one more time. So I have a Blue Hospital. I collected the data. I checked. I collected 30, 40 samples from this Blue Hospital. How much time on an average you take to discharge a patient? We found that 200 minutes is the average, and the standard deviation is 30 minutes. So what will be the performance of the hospital? Like how 99% of the patients in this hospital will be discharged within what range? So we know that plus minus 3 times standard deviation has 99% of the population. So I can easily predict that, okay, 200 minutes is the average, 1 standard deviation, 2 standard deviation, and 3 standard deviation, and minus 1 standard deviation, and minus 2 standard deviation, and minus 3 standard deviation. I've got the process on the left side. So population, I'm trying to predict the population, not the sample. Sample I am already aware of. Sample from Blue Hospital look like this: 200 minutes, 210 minutes, 190 minutes, 170 minutes, 145 minutes, and so on and so forth. None of the sample is going up to 110. None of the sample is going up to 290. But on what basis I am predicting about the population? From the Gaussian curve, from the normal distribution curve, I am predicting that there is a possibility. Although in these 30-40 samples, I am not getting the 110 to 290 minutes of the patient, but I'm sure if I discharge around 1,000, 2,000 patients, or if I had all the data of the patient, some patients, very few patients, would have taken 140 or 110 or even 260 to 290. So is this clear with the Blue Hospital? Are you with me on the Blue Hospital. This is the performance of Blue Hospital. Please let me know if you've understood this part. Now let us look at the Green Hospital. Now Green Hospital average is 260. This is 260. And 10 times right, 10 times. See, for one standard deviation of Green Hospital is how much? Because standard deviation is now different here. For Green, it is different. Even the X bar is different. So for Green Hospital, it will look, if I just draw a Green Hospital separately, it will look something like this. 260, one standard deviation, two standard deviation, and here it will be like, so 260, 70, 80, 60, 70, 80, and 90, and it will be 230. You can fill in those numbers, 270, 280, and so on. So this Green Hospital, did you understand? How did I draw the curve? Based on the same Gaussian curve. So I'll place this Green Hospital here. Okay. Now if I ask, or senior management says you should not go beyond 230 minutes. This is your KPI. Specification limit. You should not go beyond 230 minutes. Now in the Blue Hospital, there are, I think, 30% of the patients going beyond 230 minutes. So they are making some errors, defects in the process because they are late more than 230 minutes. And for Green Hospital, almost 100% of the patients are taking more time. Now, the approach of a CPHQ professional or quality professional would be different with Blue and different with Green. For Blue, the approach would be reduce. See, there is no problem in the centering. Centering is perfect. Central tendency, there is no issue in the Blue. Problem is in the variation. In this hospital, maybe people are following different processes, or they are not aware of the all the staff is not aware of the proper procedure. They're not well trained, or even they're trained but they don't follow the process, and someone uses their own method. So some people are taking very less time, and some people are taking too much time. The reason can be anything. It can be related to procedures, or it can be related to the variation of the staff or the experience of the staff. It can be anything. So my suggestion as a quality professional for Blue Hospital would be reduce the variation. Reduce the variation. And for Green Hospital, there is no issue in the variation. People are following the standard operating procedure. There is no variation. Most of the people are, the variation is very, very low. They're very precise. They're very, very precise. Problem is not in the variation, because they're following all SOP exactly the way it is written. Teams may change, morning shift, day shift, night shift, every time. Performance is same. But maybe the SOP given to Green Hospital itself is faulty. So I need to maybe change that. So here I would say Green Hospital has got a problem in the central tendency. I need to shift the central tendency, bring it towards the left. But is there any problem in the Blue Hospital with respect to the central tendency? No. Central tendency of Blue Hospital is right. It's okay. Problem is in the variation. So if your variation is low, you say, I am precise. If your variation is high, you say, I am not precise. If your central tendency, is exactly where it should be, we say we are accurate. If central tendency is off the mark, then we say we are inaccurate. So if I were to use that often used example, so this is the okay. So blue hospital, if I want to represent, it will look like something like this. Now I want to hit the target, isn't it? So blue hospital is something like this, and the green hospital is something like this. So we say green hospital is precise, blue hospital is accurate. On an average, blue hospital knows where the target is. Both are problems. So ideal hospital would be something like I can say red, like if I put, should be precise as well as accurate. So you're accurate also, and also you're precise. Whatever you do in your service, in your hospital, in healthcare, you should be both accurate and precise. Means you should first, on an average, your average performance should be good. Sometimes we are very happy. On an average, my KPI target is, like if it's blue hospital, would be very happy. My KPI target is how much? 230. How much is my performance average? 200. Now the blue hospital will be very, very happy. You ask anyone, like, what should be your average waiting time of patient? 30 minutes. And what is your performance? Aha, we are at 20 minutes. You are very happy. But what about your standard deviation? People forget about the variation. So both average, both central tendency and variation are important to understand, are you satisfying the customer? Are you operating within your specification limit or not? So both accuracy as well as precision are required. So this is your blue is, I'll just write it. Blue is accurate. Accurate. And green is precise. You should be both, of course, precise and accurate. Something like, I just put it here, black. Something like this. Black is both accurate and precise. So it is true with your blood sampling machine, or also blood sampling equipment. You give the same blood sample to two different equipment, and then sometimes you get too much of variation or too much of the difference is there too much. So this philosophy is applicable almost in all the processes. It can be in lab, it can be in pharmacy, it can be in surgery, it can be in waiting times, registration times, in finance and billing, everywhere. This, as long as you understand the concept, that's fair. Now, we should be both accurate and precise. Now, but how? I should do a root cause analysis. Before we go to the inferential statistics, we also need to understand something about the confidence interval. So just to tell you, in the 18th century, Mr. Gauss, he studied without computers, without laptops, without calculators. He could find out these relationships. So just to little further expand on this, X bar, you have 1 and 2. This is plus 3 times standard deviation minus 3 times standard deviation. This is plus 2 times, this is plus 1 time, minus 1 time, minus 2. So he found out that plus minus 1 time was 68% approximately. Understand the concept, don't worry about the exact numbers. This was approximately plus minus 2 is 95% of the population. So I can start predicting about the population. And plus minus 3 is 99%. Okay, 99%. I'm talking about approximately. There are some decimal points as well, but that is like of theoretical importance. Okay. So if I ask you, tell me 95% of the patients in the blue hospital, given this data, are being discharged within what duration? 95% of the patients in blue hospital are being discharged within what duration? So this is plus minus 2, isn't it? Plus minus 2. So what is the plus minus 2 duration for blue hospital? Minus 2 is corresponding to what value, and plus 2 is corresponding to what value? So this, you see, 200 is, this is 200. Plus 1 times standard deviation is 230. Plus 2 times standard deviation is 260. This is minus 1 times standard deviation and minus 2 times standard deviation. So what are the 95%? 95% of the patients are being discharged within what time? Yes, it is 140 to 260 minutes. So I'm 95% confident that patients in blue hospital are being discharged between 150 to 260. I will say this is my 95% confidence interval of the discharge time. This is 95% confidence interval of the discharge time. What it is? 140 to 260 minutes. Means, in other words, I will say 95% of the patients will be between 140 to 260. So I'm 95% confident that 95% confident that patient will take 140 to 260. So out of 100 patients going to this hospital, blue hospital, 95 will take within this time, 5 will take more, 5 will take more or less. Or 99% confidence, I would say 110 to 210. So please remember, when I say 99% confidence or 95% confidence, it has nothing to do with the quality. It is just making a statement. I'm describing something. It has nothing to do like 99% quality. No, we have not arrived at the quality. We're just making a statement about a process that I'm 95% sure the patients will take 140 to 260 minutes. Is this understood? Is it clear? If you have any questions, please let me know. 95% confidence, 95% band of the discharge time. Now this 95% band of waiting time, you can calculate. 95% band of time taken to perform a surgery, you can calculate. 95% band of your medicine dispensing time. This all time. We are talking about the total time. We'll come to the mean. There is another band for mean as well. We'll talk about that later. But as long as you understand the plus minus 2 means 95, plus minus 3 means 99, and plus minus 1 means 68% of the patients are taking between 170 to 230. Okay, so now I think we have touched upon quite a few of basic statistics. We have understood. If you don't have any question, so I'll just revise very quickly whatever we have covered, and we'll take a break. So there are two types of data. There are two types of data, continuous and attribute. Okay. Two types of data, continuous and attribute. Continuous data can be represented on a number line. Attribute data can be represented as categories. Continuous data will have a unit and a decimal place. Attribute data will have counts on the categories. So it is also known as discrete data. Sometimes we call it as discrete data. Why? Because it is expressed discrete counts, 5 or 6 or 7. You cannot have 6.1 times I felt having pain. You can't have 40.2 patients are satisfied. You cannot have a decimal. If I am looking at the continuous data, I will look at the descriptive statistics. If I'm looking at descriptive statistics for both, in fact, we can look at continuous and attribute. If I'm describing the performance of my process, if I'm collecting the data as continuous data, I will make a histogram or a normal curve. For attribute data, I can make a pie chart or a bar chart. All the processes, they follow normal distribution curve. Plus minus 3 times contains 99% of the population. So I can take a sample, I can make a judgment about the average and the standard deviation. Based on the standard deviation, I can predict about the larger population. Minus 3 times standard deviation is known as lower control limit. Upper control limit is plus 3 times standard deviation. If I make the lower control limit and upper control limit as horizontal lines, then if I express my process performance within those two lines, we call this as a control chart. We can call it as a control chart. We say process is under control if it is operating within the lower and upper control limit. Process is out of control if it is going beyond that. When the process is out of control, we say there is a special cause in my process. When process is within the lower control limit and upper control limit, we say we are in common causes. And then lower and upper control limit are also known as vice of process. Both are important, central tendency and variation. We saw the central tendency can be mean, median, and mode, and the variation can be range and interquartile range and standard deviation. We also saw the formula of standard deviation, and of course, we saw that both are important, central tendency and variation, and you should be both accurate and precise. We also saw that plus minus 1 standard deviation has 68% of the data of the population. Plus minus 2 has got 95% of the population. Not a sample, please remember. Sample, I'm not interested in a sample. Why I'm collecting a sample? Because I want to predict about the population. And similarly, plus minus 3 sigma has got 99%. So on that note, let us take a break and then we'll be back after 1 hour. So let's take a prayer break, and after that we'll be coming back.
This conference will now be recorded.
Okay, so we had seen the descriptive statistics. Now let us look at the inferential statistics. So in the inferential statistics, we would like to make inferences about the factors. So if I'm trying to improve any factor, so let us say if I take the example of our discharge time of patients. Discharge time of patients. And if I find using a cause and effect diagram or a Ishikawa diagram, also known as Ishikawa diagram, also known as fishbone diagram, cause and effect, Ishikawa or fishbone diagram. That some of the factors which are affecting my discharge time are discharge summary time, and let us say sometimes the inaccuracy of reports that also might affect report inaccuracy. Sometimes errors in the report might affect my discharge time. Time taken to do the billing or insurance, staff availability. Can you give me some examples, some reasons? Staff not available, yeah. And maybe medicine dispensing time. Billing time, yeah. Billing, insurance, and so on and so forth. Doctor not available. Yeah. So I have written down these X factors. Now these X factors or all the Y and X factors, all of them, you will see that they will be either continuous or attribute. So the discharge time is continuous data, and then discharge summary time is continuous data. Reporting accuracy, is it continuous data or attribute data? Continuous attribute data, yes. Doctor unavailability, availability is again attribute data. Billing time, medicine dispensing time is continuous data. Staff available, not available, attribute data. And insurance time is continuous data. So let us take some few examples and some combination. So if I wanted to just know about the discharge time, I want to just talk about the discharge time, I can do a histogram. But if I want to know if the discharge time is getting impacted by one of the X factors, then I will do a hypothesis test. So what is hypothesis test? Let me talk about it. Hypothesis test, we won't go into the details because as a CPHQ, you don't have to really go into the details. You should be aware of some of the hypothesis tests. That's good enough. How to do a hypothesis test and what are the interpretations. All these things are not in the scope or not in the scope of discussion of CPHQ exam. But briefly, I will tell you about it because you will understand some of the other aspects which you are supposed to know. So some of the basic tools, if I were to use some of the basic tools, so like once I have done a cause and effect diagram, so anytime if I'm doing a PDCA project, if I'm doing a Six Sigma project or a lean project, if I'm doing some improvement in the process, usually I will have to make some statements, both descriptive as well as inferential statements. So the first step towards root cause analysis could be a cause and effect diagram. Once I have collected all my causes, you can use brainstorming technique. You can invite people from various departments and they can brainstorm on all the possible causes. And the first brainstorming is not on the solutions, how to reduce the discharge time, but the first brainstorming can be on the possible causes. What is causing the delay in discharge? So here, if I look at this, I can say that I might have listed around 10 to 15 causes. Now, I won't work on all the 10 to 15 causes. I would have to filter them down. I have to zero down on some of the root causes. So one of the tools which you can use here is a Pareto analysis. Pareto analysis, also known as 80-20 rule. 80-20 rule, 80% of your problem, 80% of your problem, we call it as this is the Y, these are the X factors, this is the Y, and this is the X factors. So 80% of your problem in the Y is due to 20% of the X factors. So here I would try to find out which of these X factors are having more impact on the Y, on the output. So one of the ways to do a cause and effect, the Pareto chart is I collect the frequencies of occurrence of those causes. How many times each of these causes appearing? So I can collect the data on all the possible causes and how often each cause appears, causes and frequency. So let us say I will take the first cause as discharge summary time, discharge summary delay. Second is report error. Third is staff availability. So you will list down all the possible causes. Medicine dispensing time. Like I can say pharmacy time, pharmacy related formalities, and I will keep on listing down all the causes, and I'll just right now for the time being maybe add one more, which is say physician not available. Okay. Now I collected samples of 100 patients, let us say. for my ease of calculation. So let us say, if I want to show the calculations, then I collected 50 patients who were delayed beyond specific, let's say delayed beyond 2 hours. And I found that around, say, 20 of them got delayed because of the delay in discharge summary. And it took a lot of time to write the discharge summary. 15 were due to some reporting errors. 2 were because of the staff was not available. Then 5 were because of the, let us say 10. Yeah, 10 because of the pharmacy took long time. And 3 was because of the physician was not available. Now I will arrange this in descending order. Descending order: 20, 15, 10, 3, and 2. And of course, I will interchange these positions, which I'm not doing right now. And then after that, I will calculate the percentage. Percentage means 20 divided by 50 is percentage wise, it will be 40%. This will be 30%. This will be, okay, I think this I can make it in order to make it 5. So 35, yeah, so it is, yeah, so 20%, 6%, and let us say 4%. And of course, I will have many more causes which I have not written down. It will be now 100%. And after that, I will write down cumulative numbers. So 40 is 40, 40 plus 30 is 70, 70 plus 20 is 90, 90 plus 6 is 96, and this is 100. What is cumulative? First 2 together is giving me 70, first 3 together is giving me 90, first 4 together is giving me 96, and so on and so forth. And just as I told you, there won't be 5 causes, there can be many more, and I just assume that we have 5 more causes, and every cause is having like 0.5, 1%, etc. So I'm just not writing it down for the simplicity of explanation. Now what I will do, I will make a chart. I will create a chart. And this chart would look something like this. The first one, the highest one is discharge summary time, which is approximately the number. So frequency is here. And if I convert this into percentage, so percentage is here. So total 50, this is total, corresponds to 100%. The first one is 20%, or 20, number of is 20. 20 corresponds to 40%, which is discharge summary time. The second one is reporting errors. So I'll put it here. reporting errors. The third one is pharmacy time. So I'll put pharmacy here. And the fourth one, and the fifth one, and the sixth one, and of course, all the 10, I will write it down. Then I will create a cumulative frequency. The first two together, first one is how much? Percentage-wise, 40%. First two together, first this one and the second one together is how much? 70%. The first three together is 90%. Then the first four together, 96%. And then so on and so forth. You will create this cumulative line. So this is the cumulative line. The cumulative. And then at around 80% approximately, I will say that these two causes are approximately 80% responsible for my total problem. Means if I just focus on the first two or at the most first three and remaining 10 causes I can ignore, I can solve 80% of the delays in the patient discharge time. So this is how I do a Pareto analysis. So one of the questions could be, you can be shown a Pareto diagram and you would be asked a question on that. One question can be, what diagram is being used to analyze the causes of some problem? So answer would be Pareto. Or in a Pareto, which of the causes are responsible for 80% of the problem? So in that case, you will be looking at the top causes, and then you write the answer, or you choose the answer. It's a multiple choice question, of course, so you can choose the answer. Any questions on the Pareto chart? So we have seen cause and effect diagram, Pareto chart.
This conference will now be recorded.
Now after this, I will start investigation. Between the y and the x factors, one by one. Okay. So first, I will create, because this is a scientific investigation, so I will give equal opportunity to all the possibilities. So what are the two possibilities? Now I am into inferential statistics. I am trying to draw an inference. Why the discharge time is high? What is affecting the y? Which of the x factors? We have got so many x factors. So this is x1, this is x2. Which of the x factors is affecting the y? So first I will make an assumption as null hypothesis and alternative hypothesis. Null hypothesis is, we will say that x does not affect y and x affects y. X does not affect y and x affects y. Or in other words, I am writing x is significant. Sorry, x is not significant, and here x is significant. So x is not significant and x is significant. So there are two possibilities. X is not significant, x is significant. Like in vaccines, we say a vaccine is not effective. There's no relationship between effectiveness and this vaccine, or it is effective, right? So null and alternative. So first I'll give you the model, and then we will take some examples, and that will help you to understand the things in a better way. So first, let us look at the null hypothesis. Null hypothesis: X does not affect Y, X is not significant, X is not the root cause, and alternative is X is the root cause, X is significant, X is affecting the Y. Okay. Now let us take an example. So there would be different combinations. If I take a combination like something like this, looking at the discharge time. Discharge time is continuous data, and let us say discharge summary time is also continuous data. Okay. So if you look at this type of combination, this is continuous data, and this is also continuous data. So when we are dealing with continuous and continuous data, when we are dealing with continuous, so let us look at first possibility. Both data are continuous. Then we will see one is continuous and one is attribute. Anyone is continuous, anyone is attribute, either way. And the third possibility, which is not displayed here, but would be something like this. When this is attribute and this is also attribute. Both are attributes. So there are three possible situations. One is continuous and one is attributes. Both are continuous or both are attributes. So all the three possibilities, different tools will be used. The first one, continuous and continuous. So both the cases, what we will do, we will first do the graphical analysis and then we will do the hypothesis test. In fact, all the cases we'll be doing the hypothesis test after the graphical analysis. But if I want to create a generic model, so let me talk about the model first, and then after that, I'll give you an example. So sometimes it is difficult to understand model if you're not exposed to hypothesis test before. So you may be not having, you may find it a little difficult to understand this. But stay on for a while. You'll understand everything once we start giving the example. So first we have the null and alternative hypothesis. Then we choose our alpha value. Alpha value means usually it is 5%. Level of significance, we say. Level of significance. So 1 minus alpha becomes 95%. So that becomes our confidence level. Okay. So all the statements we'll be making using 95% confidence. So all the statements we are going to make using 95% confidence. Means discharge time is affected by discharge summary time. I'm 95% sure that it is affected by discharge summary time. That is my statement. This is how I'll be making a statement. So null hypothesis is discharge summary time is not impacting the discharge time, or reporting time is not impacting, billing time is not impacting the discharge time. That will be the null hypothesis. And billing time is impacting, billing time is significant, billing time is root cause, will be the alternative hypothesis. Okay. So right now I'll just describe the model. So alpha is 5%, 1 minus alpha is 95%. After that, I will conduct a test. I'll conduct a test. So there will be different tests chosen. We will talk about this. So either I will do a t-test. Mostly, let's look at the t-test only, or even ANOVA. When the combination is continuous and attribute. So one is continuous, one is attribute. If both are continuous, I will use correlation and regression. If both are continuous. And if both are attributes, I will use a 2p test or chi square test if both are attributes. So only one, given a situation, only one possibility, only one test you can use. Then you will obtain a p-value. Now you don't have to really get the p-value, don't have to calculate, you don't have to find the p-value in CPHQ. You're not going into so much of details, but you will get a p-value. It can be conducted, but understand the meaning or understand the importance of p-value, use of the p-value. So if p-value is less than alpha we have chosen as 0.05, 5%, isn't it? If p is less than alpha, here p is less than alpha, if I just put alpha, then reject h naught and say that x is the root cause. X is the root cause, and if p value is more than 0.05, then accept h naught. Okay, accept h naught. So p value is less than 0.05, reject h naught. P value is more than 0.05, accept h naught. Okay. So here you are fine. Okay. Using an example, I think you will be able to understand this better. And instead of hypothesis test, you can also first do a preliminary test using graphs. So graphical, if you want to use graph, for continuous and attribute, you will use a box plot. For continuous and continuous, you will use a scatter plot. And for attribute and attribute, you can use a tables. Use a table. So let us choose the first one. Let us say I will choose the first combination of both are continuous. So one of the examples could be is time taken by the pharmacy, or let's say discharge summary time. Let's say discharge summary time. Is it affecting my discharge time of the patient? So discharge summary time, the physician is writing the discharge summary time. Is it impacting my discharge time? Let us see. The first one is I can begin with a graphical analysis. What is a graphical analysis here? Which graph I can use? These are the graphs. Which graphs I can use? Here I can use, I'm looking at both continuous and continuous data. So I can use scatter plot. Okay. So I can use a scatter plot. So what I'm doing is I will plot So I will, first combination is continuous and continuous. And the example is, what we are taking here is discharge time. Is it impacted by time taken to write the discharge summary? And first thing I can do is scatter plot, and after that correlation and regression. And here discharge summary time. Now, if I find that as the discharge summary time is increasing, the discharge time is increasing, I will say there is a positive relation. If I find, very rare, but everything is based on data, right? It may happen. This is a possibility, in fact. The discharge summary time and discharge time, there is no relation. When I take 15 minutes to write a discharge summary, still I take sometimes 2 hours, sometimes 4 hours. And when I take 60 minutes to write a discharge summary, still I take sometimes say 1.5 hours to 5 hours. So here I would say no relation. And then there is a third possibility also. Sometimes in some situations you can have a relationship which is negative. This is negative relation, like experience of the person and time taken to complete a job. Thank you. Now, if you are doing graphical analysis, then in that case, you can work on correlation coefficient. Pearson correlation coefficient. Pearson correlation coefficient is expressed by R. It is a value of between -1 to +1. It has a value of -1 to +1. In between there is 0. This is negative correlation. This is positive correlation. Strong positive, strong negative. So what is strong positive? If all the points are lying on a straight line, exactly a straight line, all the points are lying on the straight line, then we will say that we have R equal to +1. Or if something like this is there, we say that exactly straight line, then we say that R is equal to -1. And perfectly no correlation, then we'll say R is equal to 0. But in real life, situation won't be like this. So it would be somewhere, some scatter will be there. So I will say R is equal to maybe a plus 0.8. Here, if you see, so R is equal to minus 0.7. And as the scatter increases, I would say that R is equal to 0. And if I square this R, if I square the R, I can get regression coefficient. A regression coefficient. What is the regression coefficient? Square of R, which is R squared, expressed in percentage. So suppose R is 0.8. So R square can be 64%. Higher the R square, more is the strength of the relation. Okay. Now let us look at the hypothesis test, and also let us look at the regression too. When I collect two continuous data, whenever I collect two continuous data, there is a possibility of fitting a straight line. When there is a possibility of fitting a straight line, I've got an advantage of creating a straight line equation. What do we mean by that? Let us say, in my hospital, I collected the data of experience of the people and age of the staff, experience of the staff and age of the staff. Let's say experience of the nurse. So I collected the data of, let's say, 20 nurses, experience of nurse and the age of the nurse. So a nurse with 0 years of experience, age was 22, let us say. I'm just taking an example. Age, experience of the nurse is 10, so age was 32. Experience was 20 years, age was 42. Experience was 30 years, age was 52. And experience was, I think, so here, if I plot the data, it will look something like this. When it is 0, 10, 20, 30, it will be, at 0, it is, let's say, 22. At 10, it is 32. And at 20, it is 42. At 30, it is 52. Perfect straight line. Obviously, you will never get a straight line. I'm just trying to explain a concept. So that's why I've chosen a perfect straight line. And this line will be fitting into a straight line. I can always get a straight line equation which is in the form of y is equal to a plus bx, where a is the value of y when x is equal to 0. That means when here the equation will be age is equal to 22 plus experience. How did I get it? A is when x is equal to experience is equal to 0. What is the age? 22. So that will be 22. And 1 year of experience increases age by 1 year. So the B value is 1 unit of increase in X will increase Y by how many units? You don't have to go so much of detail, whatever I'm explaining. Some of you might understand, some of you might not, but really you don't have to go to so much of detail. But the reason I'm explaining is you will know the tools and techniques. There is a scatter plot and a possibility of a line, and that equation of a line
We
is
are
known
currently
as
improving an issue with your audio connection. Please stand by. This conference will now be recorded. This conference will now be recorded.
So whenever I am having two continuous data, I have got an advantage of making a prediction equation. We call this as a regression equation. Regression equation. So this is the regression equation. And R square of that equation will indicate how strong the strength of the relationship is. So approximately above 60 to 70% we'll say it's very strong. But more than that, let's say I'm just putting some value here. Here in this case, I would say it's absolutely a straight line. So strength of the correlation is 100%. Yeah, but in real life, of course, you won't have this situation. A person with having 11 years experience also will find 32 years age. A person with 9 years experience also will find 32 years age. So that's some the scatter would be there, and the R square won't be exactly 100%. But for the purpose of explanation, I've just kept it simple. More than that, if I want to know the strength of relationship, or whether age here is the Y, age is impacted by experience or not. Is age correlated with experience? See, whenever I say null hypothesis X does not affect Y, I can also interpret it as X is not related to Y. And HA is alternative is X is related to Y. So the null is X is not impacting Y, X doesn't affect Y, X is not related to Y, there's no relation between X and Y. And alternative is there is a relationship between X and Y, X is in fact impacting, X is affecting, X is the root cause. These are the null and alternative hypotheses. Now I'll look at this same example of discharge time and discharge summary time. So here, if I find there is a relationship, so if I want to write a null and alternative hypothesis, I'll say discharge summary time not affecting discharge time of patient. Okay, and alternative is discharge summary time affects, it's the root cause, discharge time of patients. So in this situation, the first situation, it is affecting. In the second situation, it's not affecting. In third situation, it is affecting. So the first situation, I will reject null, isn't it? Rejecting null means there is a relationship. A quality professional, whenever he or she conducts a hypothesis test, the whole idea of conducting a hypothesis test is to reject the null hypothesis. I want to reject the null hypothesis. So I am going to reject null hypothesis if I find a relationship. So there is a relationship. So here, most probably when there is a either positive or negative relation, either way, the p-value will be less than 0.05. Here also p-value will be less than 0.05 because there is a relationship. This is a positive relationship, this is a negative relationship, but there is a relationship. And if there is no relationship, something like this, p-value will be greater than 0.05. If there is no perfect relationship, p-value will be 1. P-value will be 1. 100%. P-value means probability of you going wrong if you reject the null hypothesis, or probability of you going wrong if you say that this is the root cause. So here, what is the probability of you going wrong if you say there is a relationship in this situation? This situation, you will be 100% wrong if you say that there is a relationship. So p-value will be most probably equal to 1. If this is the situation, like exactly the black line, there are no blue ones, perfect relationship. So p-value will be, in this case, will be 0. P-value will be 0. You will be 0% wrong if you say that there is a relationship. You will be 0% wrong. That means there is a relationship. So P is probability of you going wrong if you say that this is the root cause. So you will get a p-value. If p is lower than 0.05, you will say this is the root cause. If p is greater than 0.05, you will say this is not the root cause. And this will be true for almost all the tests. So what we have seen here, when age and experience are strongly correlated, my p-value will be most probably less than 0.05, or in this case is perfect relationship. So p-value will be 0, and value of r will be, so p-value will be 0 and value of r will be, it is a perfect relationship, positive, so it will be 1.0. Okay. Now coming back to the next one.
This conference will now be recorded.
So now let us look at the another possibility of a combination when I have got a continuous data and attribute data. So when I'm dealing with continuous and attribute data, so here again the h0 remains the same, x does not affect y, and alternative becomes x affects y, but here we'll treat it a little differently. So if I want to put again discharge time, I'm interested in let us say staff is available or not available. Availability of staff. So whenever we are dealing with attribute data, as you know, this is attribute data, right? You will have 2 or more categories. So I will create I'll have 2 categories, staff available and staff not available. What I will do, I will collect the data of discharge time of patient when staff was available. So when the staff was available, the discharge time was 200 minutes, 201 minutes, 202 minutes, 203 minutes, 204 minutes, 200 minutes. And when it was not available, 300 minutes, 302 minutes, 303 minutes, 304 minutes. What do you think? Staff availability, is it a root cause? Is it the root cause? Looking at the data, so might be, yes. The way I have made the data, okay, so you are very expert in statistics, and that's the right way to put up that, yeah, might be. So you will create both null and alternative. So null is, it is not affecting. So I can also write the same null and alternative in this another way in terms of mean. Mean discharge time when staff is available is equal to mean discharge time when staff is not available. Means it doesn't impact. Availability of staff is not the root cause. And another can be available when the staff is available. What do you suspect here? When the staff is available, the time taken is a little less. You know, it's in 200s, and here it is in hundreds. Okay. So this will be my null, and this will be my bottom. Now here I can't draw. So can be, yeah, who will do the process without a staff? Okay. Okay, not available. Okay, so less available. I would say full strength. Okay, so instead we can just instead of available or not available, I would say uh, full availability, you know, full strength. Let me correct it. Yeah, so it can be full strength availability of staff and full strength not available. So only partially. It won't happen. It will never happen that all the staff is missing, obviously. So when we say staff is not available in full strength, when I'm saying not available means it's not available in full strength. Okay. Now, I cannot make a scatter plot. I will make a box plot. So graphical analysis will be box plot. So full staff available and full staff not available. I'm talking about full staff, yeah. Availability. And discharge time. Now here, I cannot make a scatter plot. Even if I try to make a scatter plot, it will become a box plot. So when the staff is available, my time is less. When it is not available, time is high. And another possibility can be available, not available, time, the distribution of data when the staff is fully not available or available is the same. You still take 2 to 4 hours when full staff was available. You still take 2 to 4 hours when partial staff was available. So the staff availability is not the root cause. Staff availability is not the root cause in my process. Okay, that's what we will say. And if I have got two categories, here. I've got two categories, available, not available. if I've got two categories, I can do a 2 t-tests, or if I've got 2 or more, let us say, is shift impacting my discharge time? Is shift impacting my discharge time? Shift is shift A, B, C. There are 3 shifts. I collect the data. So 2 or more, I cannot use 2 t-tests. I will use ANOVA. So either 2 t-tests or ANOVA I'll be using, and based on the p-value. So here it indicates that full staff availability is the root cause. It is impacting. I'm rejecting null and accepting yes. When the time full staff is available, it is taking less time. Not available, it is taking more time. So staff availability is the root cause, and I have got a root cause. That's what I will say using a 2 t-test or ANOVA tests. So I've used box plot for graphical analysis, and hypothesis test I will use 2 t-test or 2 t-tests or ANOVA, and I'll get the p-value. So in this case, or most probably the p-value will be 1 or higher than 0.05. I'll be 100% wrong if I say that staff availability impacts my time. I'll be almost 100% wrong. And in this case, p-value might be, I would say 0, because almost I'm 0% wrong if I say full staff availability is impacting the time. So here, based on that, I'll make my conclusion. This was about 2-tier ANOVA. And the last part is when both are attributes. Let us say medication error or any error. Let's say I'll just take any error. Error or mistakes. Is it impacted by the? Is it impacted by? Let us say. Is it impacted by the are some nurses committing more mistakes as compared to others? So I've got, let's say, I will say 2 nurses, nurse A and B. So when it is attribute data, I will have 2 or more categories. So let's say I have got 2 nurses A and B, and I have got errors. Now errors, you may think that it is a continuous data, but it's not a continuous data, because actually error or mistake is a count of the quality, right? Attribute is quality, error, no error, mistakes, no mistakes. It is an attribute data, please remember that. So let me take you back to the attribute and continuous data, and let us learn a little bit more and revise that, because this is one of the common mistakes we commit. And I'll be sharing, in fact, I'll be clicking this photograph and sending it to you immediately. All the whatever I'm writing down, I'll click a photo and send it to you immediately. So not a problem. Yes. Now, once we have studied, there are 2 types of data, continuous and attribute. So this attribute data is a little tricky one. So let me talk about one, and also I'll tell you one more category of attribute data. Attribute data can be further divided into 2 subtypes: nominal and ordinal. Nominal means there is no order, and ordinal means there is an order. Like in a pain scale, you have order. 1, 2, 3, 4, from low to medium, low, medium, high, etc. There's an order. So we call such a scale ordinal scale. But attribute data like gender, male, female, there's no order. So I have 30 males and 20 females in the team. Total is 50. And the proportion is, of course, whenever we are dealing with attribute data, we'll talk about proportions. Okay. Yeah. So I'll be sending you. I'll click the photo immediately, and once we finish the course, I'll click the photo and send it to you. Yeah. Yes. Okay. So we will be talking about. So there are two types of data: ordinal and continuous. Ordinal and nominal. Nominal and ordinal. Two types of data. So male, female is nominal data. Patient satisfaction is, what type of data is patient satisfaction? Ordinal or nominal? There is an order, right? So it is ordinal. Okay. Another example, quality. Error, no error. 10 errors, 90 no errors out of 100. Proportion of errors is 0.1. Infection rate. Infection rate, tell me, continuous or attribute? Can you please tell me? Infection rate, is it continuous or attribute data? Some people might say that it is continuous data, but it is, yes. Infection rate. Why? Because although I am reporting infection rate in proportion, but actually it is although I'm reporting in percentage, but it is actually, so 298 total 100, 0.02, 0.98 total 100. I think you have got points. Now let us look at the last part. So let us say error or mistake, which is attribute data, and nurse. So if I give you a data, let's say nurse A is committing 10 mistakes and nurse B is committing 20 mistakes every day. Every day. Which nurse is better? Nurse A is committing 10 mistakes every day. Nurse B is committing 20 mistakes. Which nurse is better? So most of the people will say A. But no, now we are CPHQ professionals. First of all, you have to identify that mistakes, errors, they are all attribute data. So you'll ask for one more category. You'll ask, I'll demand, what is the other category? Tell me the other category. So you are telling me only the errors, but I'm interested in proportions, isn't it? When you are dealing with attribute data, you're telling me the counts. Count have no meaning. Count by itself, they don't have any meaning. Out of how many patients? So now I'm giving you total, the nurse A saw 100 patients. Now tell me, which nurse is committing less mistakes? In fact, both are same. I'm assuming that the category of errors is same. If you want to that way, we can also category of error. If you want, we can make it that way also. Minor errors So say, what can be the category? You tell me. Give me the categories which you use. Can you give me 3 categories? So I'll just put minor, major, and fatal. Near miss, harm, or critical. Yeah, okay. Near miss, harm, or critical. So near miss, harm, critical. Yes. Tell me which nurse is better. I'm giving you 2 sets of data. Which nurse is better? In fact, both the nurses are same. The proportion, the relative proportion is same, isn't it? So here, what am I doing? I am preparing table. This we call it as a table. What am I doing? Table of counts. Okay. We call it as table. Okay. Now I will give another scenario. Now, which nurse is committing more errors? To make your, yeah, so here in this case, most likely B. So again, here also the same thing. Our null hypothesis will be nurse does not affect the safety of the patient, or is not related to the errors, a number of errors, and HA, nurse affects, or nurse is significant. And I can also write in another format, proportion of mistakes committed by nurse A is equal to proportion of mistakes committed by nurse B, and I think in alternative is BA is less than proportion B. Or I can do a chi-square test. So whenever I'm having a table, like here, I have 2 proportions, I can do 2 proportion tests. But here I have got how many proportions? I have got more than 2 proportions. You see, I've got more than 2 proportions. I cannot use 2 proportion. Here I'll use chi-square. So even with 2 also, I can use chi-square tests. So we do a chi-square test, and then after doing chi-square test, we'll get our p-value. So most likely, here the p-value will be 1. You'll be 100% wrong if you say nurse is affecting the errors. You'll be 100% wrong. P will be 1. And here, mostly the p-value will be 0 or less than 0.05. Well, it will be 0 or maybe 0.1. 1% wrong if you say that nurse is impacting. And you can be going wrong up to 1%. In fact, up to 5% you permit being wrong. That was you have chosen. That's what you have chosen. So then you will say. So as long as you have understood the essence of p-value, confidence level, the hypothesis just used, it's fair enough. You won't be asked to do a hypothesis test, but you are expected to know about these tests. That's what I wanted to cover in the especially the high-end statistical part. So what we have done, I'll just quickly revise whatever we have covered. Yeah, so both central tendency and variation are important. Mean, median, mode, range, IQR, standard deviation, we learned about that. And then we can create a box plot when the data is not normal. Box plot is of more significance. Standard deviation can be calculated for sample. This is the formula. For population, this is the formula. Sample standard deviation, sum of squares of all the distances from the mean. Take the sum of squares divided by n minus 1. And when it is population, it will be divided by n. We saw both central tendency and variation are important. You should be both accurate and precise. That's what we saw. And in terms of equipment, the reliability and validity come into pictures, which we'll see tomorrow. Then we also saw when we are trying to make inferences, inferential statistics, when we are trying to make conclusion from a sample about the large population, we call it as inferential statistics. And especially inferential statistics is more prevalent in root cause analysis. So we took some examples. To do a root cause analysis and process improvement, we generally make a cause and effect diagram, make a Pareto chart. After making a Pareto chart, then we further start validating the root causes using hypothesis tests and graphical analysis. We have box plots, scatter plots, and tables as graphical analysis, and t-test, ANOVA, correlation regression, and 2p and chi-square tests as our hypothesis tests. These are the available tests. Still, we have some time left, so let me take you through the slides. So some of the slides now we would have understood now. So basic terms, the population. Population describes a large set of collection of the data that have something in common. And we are trying to draw a conclusion about the population. Obviously, I can't draw the conclusion about the population because I don't have time and resources to collect the whole population. So I'll draw a sample to make a judgment about the population. A statistic is a descriptive measure derived from a sample. For example, if we want to know the mean age of all Emirati bladder cancer cases, we take a proportion of bladder cancer cases and calculate the mean age. Statistic. The variable, anything which can take different values, like blood pressure, heights, weights, all these are examples of variables. Observation or measurement is the value of the variable for a single element. And data set is a set of all variables. Basic terms, again, parameter is the descriptive measure derived from a population. Usually we don't know the value of the parameter, and consequently we are estimating it from the sample, like a height. or a mean age. Bias will be there. If you are taking a sample, their sample may not be exactly matching with the population. It will be representative. It will be closely matching. But let's say if I take the average height of people in a city, like in Riyadh, if I want to talk about average height of people in Riyadh, I'll collect 100 samples. Whatever average height I get, I may get 174, but the actual height might be 175 of the whole population. But I'll be close to that. The difference will be known as the bias. Bias will always be there. This part we'll cover a little later tomorrow, but I had partly covered this part, that when you are this part I was talking about defined measure and like control is more related to Six Sigma. Six Sigma part we'll be covering tomorrow. So when why data collection is important? Data collection is important because you have to collect the data to make inferences and also make statement or judgment about the population. So data can be collected not only on output measure, but also the process measures and input measures. Not only in the Y, but also the X factors. Because Y is function of X. Y is effect, X is the cause. Y is the symptom, X is the problem. Y you can monitor, X you can control. Okay. To make a data collection plan, which data you will collect, what X factors you will collect, like patient discharge time, discharge summary time, staff availability. What are the X factors you are collecting? Who is collecting? Why you are collecting? When you will be collecting? Make a proper data collection. So we talked about two types of data, continuous and attribute. In attribute, there are two types of data, ordinal and nominal. The sample size generally is affected by many factors. Larger the sample, naturally the bias will be less. But it depends on how much time you have. If you don't have too much time to collect data and resources to collect the data, small sample size is good enough. So for continuous data, thumb rule is heuristic estimate, like to get a fairly good amount of information. For continuous data, 30 to 50, 100 samples is good enough. And for attribute data, 200 to 1,100 samples is good enough. Retrospective data collection is historical data collection. Historical means we have got the data collected from the history, looking back at the events that have taken place. Prospective means I'll be collecting the data in the future. Next 10 days, I'll collect all the patient's data. So it can be either retrospective or prospective. So there are different sampling techniques. The different sampling techniques are simple random sampling. These are the very, very basic. Simple random sampling is easy to understand but difficult to execute. Then you have systematic, like every 10th patient I will pick up and ask, how do you feel about my services? So systematic. Simple random would mean out of all the patients, I'll randomly pick up few patients. Stratified random sampling means I will categorize the patient from the orthopedics, pediatrics, gynae. I will categorize the patients, and then I'll ask 10 samples from pediatrics, 10 samples from orthopedics, 10 samples from gynae. So that is stratified. Cluster sampling means every time I'm collecting a group, subgroup sampling, also known as subgroup sampling. So these are the techniques. Random sample. Random means pick up any patient at random, any unit at random. Stratified random means you are stratifying the data. So let's say morning shift, I'll collect 5 patients. Evening shift, I'll collect 5 patients. Night shift, I'll collect 5 patients or 5 units or 5 instances if I'm trying to measure the medicine dispensing time. So I will collect the data based on the stratification. I'll stratify the data first. Systematic random sampling means every 10th patient or every 10th blood sample, I will check for reliability, or every 10th say X-ray, I will examine or I will conduct an audit. So this is systematic. Subgroup sampling means every hour, let's say I'm collecting the waiting time of the patients. So every hour I choose 3 patients and check how much time they waited and take the average of that waiting time. So I'm doing subgroup sampling, collecting a subgroup, taking an average of the subgroup and making a judgment about that population. Yeah. So these are all known as probability sampling. Probability sampling based on probability. It's random. Mostly they'll represent the population in a better way. But it might take a little time for probability sampling. So they have some disadvantages also. So you can use the non-probability sampling. So the other ones which I just described were probability sampling. Simple random, stratified random, subgroup sampling, systematic random sampling. They are all probability sampling. Non-probability samples are like purposive or judgmental experts. Let us see one by one. Purposive or judgmental means handpicking some of the samples which are more appropriate for the study. So you are predetermining the desired characteristic that I will choose all the children aged between 9 and 10. And then you will make a judgment about the children in that particular age group. Expert sampling means expert will tell you, oh, this kind of, like suppose you are trying to collect the data on errors or infections or a particular disease, then expert will tell you, you should collect the data from this area, this particular. So experts will guide you. Based on that expert guidance, you are going to sample. Consecutive sampling means it involves taking every patient who meets the selection criteria over a specified time interval or number of patients. It is the best of the non-probability techniques and one that is very often practical. So if I get a person within this age, does he have a diabetes? If yes, okay, consecutive to that, if that person is having this particular problem or not, is he having cancer or not? So if I am doing that type of sampling, I will get very, very specific information in these types of sampling, not always used, but when I'm studying a particular characteristic in a population, this can be used. Quota sampling means percentage of the persons or cases is stratified in the population. So 10% of male patients over age 55 with diabetes, with heart disease will be enrolled in the study. So I'm preparing quotas. Like I will, from where I'm going to collect the samples. So these are all non-probability sampling, means you are pre-deciding. But once you have pre-decided, then of course, in that you can collect either all patients or all samples, or you can still do a random sampling. Convenience means whatever is convenient for me. So I can go to the nearby department. Today morning I am free, 8 to 10. I'll collect all the data for the patients and I'll ask them about the satisfaction. So that is convenience sampling. And slow ball sampling means I collect the data from some individuals, then this individual will refer some more people from where I can collect the data from. So one person refers to another person, so I can use the network of individuals to collect the subsequent samples. So these are different types of non-probability. Advantages is that sometimes it's easier to conduct, but disadvantage can be lack of accuracy because you're not doing exactly the random sampling. So both you have advantages and disadvantages for of non-probability sampling. Same is true with the probability sampling. Advantages, the bias will be reduced, but disadvantages, it will take long time. Sometimes it's very difficult also. So based on the situation, based on the scenario, you can always choose your types of sample. Okay. So we were just describing, so I think we have almost come to the end of the session right now. And we have covered a lot of topics which are subsequently addressed in the PowerPoint presentation. So, but I think we are coming close to the coming close to the end of the session for the day. So I will continue further. If you have any questions, you can ask whatever we have covered till now.